Hey, it's good to see Paul here today. Let me get this organized, then we'll pick on him a little bit. It's your warning to chew fast. Again, great cases in the book for differential diagnosis for physical therapy. There's an online PDF version of it loaded up on the front main page. Those are good cases to go over kind of a Jim's clinical reasoning process in there. Now, the treatment stuff, again, I think is a little bit more of a Canadian model. Then we'll go into a bit more detail between Eric and I. But the rationales for this are very, very solid as you move through things. So we're going to take a look at this today and see how we do. If you can go through these cases and do these problems, then you will have no problem with being psychologically tortured in module 7, 8. Just kidding. It's not that bad. We will do a lot of these types of cases kind of going forward, just to kind of get us all, make sure we have the clinical reasoning component of what we want to do properly in place. All right, Paul, you ready to chat a little bit?
Nah.
Yeah, I don't blame you. Good, Eric's here. How you doing, Eric?
Doing good. Doing good.
So Paul, looks like you've probably been feverishly reading these first couple sentences in this case.
Hmm.
So why don't you take me through a person who had a hyperextension injury in a car accident 2 weeks earlier, has no direct impact in the accident, no loss of consciousness, and no memory loss. What does that sentence tell you?
I guess I'm just trying to immediately think of like red flag type stuff to make sure they're appropriate for PT.
Okay.
um, so
So
that's I guess that's good as far as like brain damage. If I'm considering should this person even be in PT,
mhm.
is the direct impact, is that like that just means that it's like whiplash, or what does that mean?
No, it means
Yeah,
they
I
didn't
would
hit their
expect
head.
mhm.
Oh, to their head.
Yeah, didn't hit their head, as far as they know.
Yeah.
Mhm. And again, this would be Jim's probably easy way to telling you, okay, do we see any type of concussive event would be this would be that. Now it doesn't completely exclude any kind of chronic post-concussive events going on, but you have no loss of consciousness, no memory loss, nothing terrible in that aspect. So though at some point I want to keep my guard up for it, we'll be thinking, okay, maybe a little bit less there. Initial pain, onset was mild, initially with an increase the following day. Paul, tell me a little bit about that statement. What does that make you think?
Mild initially, and then it got worse.
Hmm.
Um, I guess that makes me think something that happened and then the body reacted to it as the time went. Maybe as she starts moving more, like that created more issues and more pain as they did day-to-day activities.
Yeah. Is there a name for that process that probably happened to this person?
Um, yes.
It's
Um,
always the obvious ones, Paul, that are the toughest. And always feel free on the discussion boards to phone in a friend. You can let Paul twist in or the easy stuff, or you feel free to bail him out as well. Okay. Okay. You've made a lot of friends in Athletico, I can
yeah,
tell.
thanks, guys.
Hmm.
Um, I mean, I don't know what is it exactly you're looking for? Like just a delayed onset.
Person goes for a long run on yesterday night and they wake up tomorrow morning and their knees swollen. What happened?
Got
Inflammation.
yeah. Okay, that's pretty simple. Thanks for the help,
That's
guys.
cool. So let's think about this real quick. So if we have somebody that has an incident, right, that sets off, some sort of pain episode, right? So just think of somebody picking something up out of the trunk of their car, right? They feel a little tweak in their back. Doesn't bother them the rest of the day, but then the next morning they wake up with pretty severe pain, right? That interlude in between the instigating incident and the onset of the pain, that what would you look at, maybe 12 to 24 hours, something like that time frame. Typically that suggests the buildup of inflammation. More immediate onset, right? So if the person lifting something out of the trunk of their car felt an instantaneous or, relatively quick onset of severe pain within the first hour, maybe 2 hours, it suggests profound structural damage occurred, right? So if this person had mild pain initially and then increased pain the following day, it suggests that there was some damage to some tissue, but it probably wasn't something overtly severe like a occult fracture or something along those lines.
So it's just more stuff that's making us think like probably less red flag type stuff.
Yeah,
Possibly.
I mean, it's definitely the problem with the neck is there's red flags that can develop over time, right? So that's because of some of the vascular issues that you can develop in the neck and things of that sort of nature because the brainstem is there, all these different things as things get bigger, right? So if inflammatory pressure continues to build, or if there's damage to any, like we mentioned, potentially vascular structures where now things start to clot, those things occur over time, right? Or if we have a limitation of motion and then all of a sudden as motion starts to increase, do we get more pressure onto another damaged tissue? Potentially some nerve structures, potentially some vascular structures, things of that sort of nature. So the neck is a little bit different than some of the other regions of the spine with that regard. But in mild initial pain with pain that progressed into the next day, as far as its intensity, that tends to suggest, yeah, there's just some inflammation going on in there. But you gotta note the idea that if there was if the we're always interested in the onset of the pain. How did it relate to the incident, or was there even an incident, right? So insidious onset things that tends to imply that um, there was some sort of slow micro trauma that built up over time. It's kind of those forced overuse issues that we've talked about, like, okay, these tissues are taking excessive stress during daily activities, and that's what sets off the pain. Kind of like the person Dave was talking about, the runner goes running, and then, the next day their knee is swollen, right? That's a probably going to be a forced overuse thing because they didn't twist the knee, they didn't get hit from the side, they didn't bang it on anything, right? That's that forced overuse issue. So we're always interested in the onset, right? So immediate onset of severe pain tends to imply severe structural damage. Delayed onset, like what this neck patient is dealing with here, tends to suggest there was some damage, but it's probably not as severe.
So Paul, just to keep it interesting, since you're flowing, the initial pain was felt in the right neck and upper trapezius with occipital headache, along with nausea, lightheadedness, and unsteadiness. You need the next sentence, which is going to be, this is non-vertiginous dizziness. Was initially present every neck movement, but after a week or so, it was only felt on right rotation combined with extension. Tell me a little bit about some of your thought process with this. We can kind of take it slow and go through it. Again, this is more discussion, Paul, too. Just put it out there. Don't be afraid of being wrong.
Yeah,
So
yeah.
we're gonna chat about the details, okay?
I guess just like trying to decide what I think is possibly happening here. Pain
Mm-hmm.
on the right side of the neck, upper trap, could be a ton of things.
Mm-hmm.
I would be more concerned and want to ask more questions about the headache, nausea, lightheadedness, and unsteadiness, just to kind of
Mm-hmm.
like start clearing. Is it possible VBI stuff, possible post concussive type stuff?
Mm-hmm.
I would just want to see how that consistent now. Where are we 2 weeks earlier? If they like saw somebody else to
Mm-hmm.
discuss those types of symptoms to consider, do we need to do more? Again, just like, are we appropriate for PT? Do we need to do more imaging testing before we get into things? Or is this somebody that I would think is like appropriate for PT?
Okay. What about okay, so what would be kind of some of the options that would cause this dizziness then? Let's just kind of look at that again. If we're looking at, okay, we have options of dizziness here, let's go with, the obvious one here would be cervigenic origin. What would a cervigenic dizziness kind of present like in your mind?
I guess the dizziness would make sense, like with recreated with specific motions, if it's like related to a specific spinal segment. The rotation and extension could make sense, versus, let's see, the the dizziness I think could make sense coming from the neck. The unsteadiness I think is, to me, maybe more concerning, nausea and unsteadiness.
Okay. Yeah. And how's that different from, okay, let's say this was, a labyrinthitis or labyrinthine concussion. How would that likely present differently than cervigenic dizziness?
So would that be, I mean, it's like cervicogenic would be reproducible with specific motions, and then
Yeah, you'd hope that, yeah, cervical motion would reproduce the symptoms. Correct. And how about the other one?
labyrinthine.
I think dizziness you usually get with more a labyrinthine, or again,
That like
it's not
vertiginous,
100%
vertiginous
absolute.
dizziness.
Yeah, it's not 100% with that, but you would expect maybe more something in the vertiginous if it was the vestibular system or vestibular apparatus which was impacted. Certainly, some of the post like a chronic post concussive, it could be a central integration process. But if we're thinking, okay, how do I BPPV was induced by this or a labyrinthine concussion? You're looking at something that'd be more vertiginous, stronger,
Sure, sure.
lightheaded, the lightheadedness and unsteadiness could be with that, but it's more consistent with a type 2 dizziness. Does that make sense?
Yeah, 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 yeah.
Anything else in there, Eric? So, you can work out cervical, you have vestibular, you know,
Yeah, I mean the
you
the
know,
hard part with any type of dizziness that you get,
mhm,
especially if it's a post-traumatic thing, is the two things that you kind of go through that when we go through the process of looking at, potential VBI stuff and things of that sort of nature, especially with the traumatic screening stuff, is you end up with a situation where it's just like, well, it could be VBI or it could be cervicogenic. And those are kind of the two things that you narrow things down to, right? So if it's labyrinthine stuff, all you need to do is stir the labyrinth up a little bit, right? So basically what we usually do is we kind of hold the head in place and we just kind of spin the person around like this so that the head and neck don't move, but we're affecting the inner ear, right? And so if that's the case, then that should make her worse as far as the dizziness goes. And again, it would probably more likely be a vertiginous dizziness type 1 than a type 2. If it's not, if it's affected with moving the neck and not the, kind of either that stir test or any of those other things that you can do with that, then it's more likely to be either something cervicogenic or something that is affected by movement of the neck, which again, the artery could be, right? So those things, you kind of move down the line and looking at, okay, well, 2 weeks out, odds are I'm not very real likely to do a lot of manipulative techniques with this patient anyway, because 2 weeks out, when you look at the structure of the artery and how things get damaged, is it's usually tearing of the intimal layers, right? So if we have the artery and the intimal layers, the inside of the artery here, right? The tunica intima, and basically you get a little tear in the flesh of that, and it creates clots, right? So it's been demonstrated that typically if you have a thrombus that's built up because of intimal tearing, it takes about 6 weeks for it to resolve, to be reabsorbed by the body. And so that tends to take away that particular danger, right? But within that first 6 weeks, you want to be very cautious about what you're doing with somebody's neck as far as hands-on treatment stuff. So again, this is kind of why we will typically gradient our our examination process as well, going from the least stressful to the more stressful stuff. So the good news is this patient's gone through a couple of weeks. The dizziness went away by the first end of the first week, it looks like is what it's saying. Um, then it did come back, according to the second paragraph there. So disappeared after 1 week, and then by the end of the second week, it came back, right? And so it was more, again, typical type 2 dizziness, giddiness, nausea type stuff as opposed to vertiginous things. So that's a good thing because when you're looking at it from that perspective of, okay, over time, if things are starting to heal, right, things are starting to potentially get better. Now, 2 weeks isn't a ton of time, probably still relatively in the pretty close to the inflammatory phase, right? So the initial inflammatory phase from the injury. So you're still pretty early on in the process here with the healing stuff. But if they start to increase their range of motion and then the dizziness starts to come back, then you start worrying about what am I stressing as I'm improving this range. where now I'm all of a sudden getting some sort of change in those sort of constitutional things. So that's kind of the only other stuff that really jumped off the page for me. Um, nothing terribly crazy there down to where we get to the discussion portion. So yeah, other than that, nothing much. You muted yourself, Dave.
Sorry, there's a loud talker behind me. So Mitch, so what tells you that this is or is not a fracture from this first section, or what would you think about a fracture? This is Mitch must have thought it was all gonna be Paul today.
No,
There he is.
for me, when I read the first section, the fact that there was like no direct impact made me think that it wasn't like an impact fracture or any type like that. But then I was going off of fracture and compression aspect of it. I just the pain doesn't seem like it was nearly as bad as I would expect from a fracture initially. But I could be wrong on that. That's
What would you expect a fracture to look like if this was a fracture? How would the story change?
I would imagine the initial pain would be a little bit higher,
Mm.
and then wouldn't change too much. Let me think. And then would there be like a feeling of like instability, like they would feel unstable? Would that be kind of
It
not
wouldn't
really?
probably wouldn't be moving enough to be unstable.
Gotcha. More
Fracture,
guarding.
you can have severe pain and splinting. This person will not be moving their neck.
Okay.
It would depend on the severity of the fracture and where it is as well, right? So if we're looking at a high cervical fracture, yeah, Dave's 100% right. They'd be doing this stuff all the time. This is how they'd be moving around. They wouldn't be turning their neck. They certainly wouldn't be getting into right rotation and extension if they had a high cervical fracture. Now, with a hyperextension injury, could you have an intra-articular facet fracture? Sure, you absolutely could, right? Could you have a compressive type fracture of the vertebral body? Yeah, maybe. Could you have a, oh man,
Hubbler's fracture, the spinous process.
yeah, or yeah, clay, is that called a clay shovelers?
Clay shelters, yeah.
Yeah, yeah. I was trying to think of the name of it. Yeah, things like that can definitely happen, and so you're not going to have as much splinting with something like that because there's just it's not as dangerous as a high cervical fracture would be. So yeah, I agree with you that you could definitely have some feeling of instability there if it was something more severe. But given kind of the movements that they've had, the symptoms that they've got right now, and that, like I said, getting into right rotation with extension tends to make me think of a high cervical fracture is really unlikely. But you could have other structural damage elsewhere for sure.
So with the different types of fractures you listed, would that change like the pain eased off after 2 weeks? Would we see a change per fracture, or would they all kind of just stay at that like intense splinting slash high pain, or is that just not a good thing to indicate off of? I guess.
And again, it would be problematic based on which one we're talking about. If we're talking about an intra-articular fracture, anything that's going to increase compressive forces in that would make it worse. So extension and rotation to that side would probably do that. Side bending to that side would probably do that. If we had more vertebral body fracture from a compressive type force, that would more likely be worse in a weight-bearing position, right? So it might not be as bad with them laying down, but then when they go to sit up, it would probably worsen over the course of the next, hour to hour and a half, something like that. A spinous process fracture would be a little more it's going to end up being a little more kind of schizophrenic on us
Mhm.
because it's going to be based on what attachment points are being stressed with that. So again, the paraspinal musculature and things of that sort of nature that will attach to that spinous process. Anytime they're activated, that would make it more painful. So you'd have more pain, say potentially with maybe resisted rotation, like rolling over in bed, things of that sort of nature. So it's tough to say. It would all depend on the severity of the fracture. A hairline thing, it probably would improve relatively quickly. But again, you just kind of have to take into consideration where it is and what forces do that particular structure deal with, right? The vertebral body deals with compression, right? The facet joints in the cervical spine are not supposed to deal with compression, right? Not from weight bearing anyway.
Okay.
So
We'll always get stories, and Eric has seen it as well, where you can say, okay, somebody has a Dens fracture, which gets missed in these cases. So they're splinting and shunting for a while, but maybe the initial X-ray is negative or it gets missed, they get brushed over, but they persist on. They get better, but they're not great.
yeah, I mean, you can have Dens fractures that get missed. I mean, if you think of a patient that has a trauma like this, they're in a car accident, maybe they do hit their head on the steering wheel, this airbag doesn't go off, or it's an older car or something like that. Um, those sort of things can cause that sort of damage. But then, say they get put into a collar, with potentially the paramedics, or, it's just like, oh, we went and see my primary care, and they put in something like that. And it's just like, okay, then you're splinted automatically, right? You're not going to be moving much in a collar to begin with. Right. So you don't notice that you're functionally so limited because they put you in this thing, and it's kind of limiting you anyway. Right. So that'd probably be the most likely scenario with that. Because obviously, if you have some sort of trauma like this and you have severe loss of range of motion, I mean, looking at the Canadian C-spine rules, you should automatically be getting X-rayed, right? But it can be missed on X-ray as well. Um,
I actually had one when I first like started uh, working that presented similar presentation to this, and I kind of wish I knew more then because they came in for vertigo, and I did like a vertigo treatment, and then they came back and like, oh, it feels worse, and I was like, oh, that's not good. So then I started asking my boss, and did it feel um, like the transverse and uh, different like integrity tests basically, and she like failed a couple of them, and I was like, you should go to the hospital now, and never heard from her again. So I don't know what happened, but it was one of those moments where I was like, hey, that would have been cool if I knew more in the beginning to like look at this.
Yeah, the only one I've ever seen was a non-traumatic one. There was this gal that came in and saw me, really frail and thin, and um, she'd been bouncing from one doctor to another, continually getting prescribed steroids. So she'd been on them for years. And I was just like, how did this slip through the cracks here? Because she came in and she couldn't move at all. Like, I'd ask her to turn her head and it would be like this and it would be like that. And I'm just like, this is no good. So I did a shear test, lateral shear test, right? So instead of doing the transverse ligament test, I did the lateral shear because what it does is it kind of takes the dens and kind of rolls it around the backside of the um, canal there on C1, and so it's less likely to create any brainstem issues. And it was just so soft, and then all of a sudden, just this massive spasm kicked in to hold it in place, and I'm like, yeah, we're putting you in a collar, and we're sending you over to the emergency room because there's a decent chance if you sneeze on the way out of here, you're dead. And I mean, I didn't tell her that, but that was kind of the thought going through my head, right? It's just like, God, this woman could she's a ticking time bomb. Um, but yeah, I mean, she'd seen other PTs, she'd seen chiropractors, and I'm just like, how are you still walking around without, major complications here? So they do happen when they're quote unquote missed. Like I said, hers was probably more of a, prolonged steroid use. Like I said, she was really thin, really frail, all these, and she was in her 50s, and it's just like, so she kind of matches up a lot with somebody that's going to end up with some sort of osteoporotic fracture, which is probably what ended up happening to her. But um, yeah, not good when you see that stuff. But I'm not terribly concerned about this with this particular patient based on their movement so far, at least what we know of it.
Yeah, it really is kind of like it's kind of like it's like taking like I would say a microscope and zeroing in and zooming back out on these different conditions. That's kind of what we do in the clinical reasoning process, like coming down the Jim's discussion where he'll go further on to about, okay, this lady's dizziness, and that, okay, brainstem concussion, or essentially mediated one, or medication, labyrinthine concussion, cervical damage, or vestibular vascular ischemia. Those are all things that okay, if we want to rule these out, we have some things that we can do and test. But then what is the likelihood ratio of each of these? So like that Bayesian theorem one is like, okay, I'm operating on the assumption in the information I'm given that this is probably cervogenic in origin. But hey, a part of me, I want to go back and do my bias correction and say, okay, why is it not some of these other areas? Like Mitch, like what would be one way? Let's say you think, and you'll mention brainstem concussion, but let's just call this a okay, mild post-concussive event. What are other ways you can look at to say, okay, is this a central integration issue? What's the kind of the classic tests that are out there for that? Can you think of one?
Not really. I don't have a lot of experience in that, to be honest.
Well, what's
Okay,
in the brainstem?
Sorry, my computer just cracked it. What'd you say?
What's in the brainstem? What's in the brainstem that we're interested in?
Now you're making me do anatomy again.
I keep telling you guys, got to know your anatomy.
Yeah. Ooh,
Oh, you might have a friend on the board.
look at that. Austin's helped me out here. What Austin said there.
Austin said, yeah. Oh no, I thought Austin wrote cranial nerves. He's not such a good friend, is he?
Oh, cranial nerves. There we go.
Those are in the brainstem.
Yeah.
Most of them.
It's
All but one of
that
them.
moment when you get put on the moment, you forget everything.
Well, this is terrible to do this, isn't it? At a point, again, that's why I don't want you to feel bad about not knowing something or saying,
Oh.
I don't know. I don't know is a great answer because most of the time it's just that there shouldn't be pressure with this, but there is. So the simple things elude us.
So are you
So,
trying to get towards like the cranial nerve testing, like what we did
yeah,
earlier?
if you think about like VOMS testing, which has become quite popular, just eye tracking, head, your best balance tests, you can quickly screen through those different subsystems. So a lot of your concussion-based testing there is easy. So it can be eye tracking, VOR times 1, 2, cancellations, head impulse test to be in there, throw in, the balance testing. You quickly screen through there, but cranial nerves are going to give you a good idea. If you test cranial nerves real quick and something's off, well, then, you're off. If it's more of an integration issue, then the speed of tracking of those types of things will show you that, okay, I think this is a brainstem concussion. You may not get the pure cranial nerve, but you'll generate the symptoms. The dizziness, the disequilibrium. That's where the VOMS test will come in handy, just as a screening tool. Is Austin raising his hand to give up, or does he have a question?
I
I don't
actually
have
have a
one.
question.
Okay.
I actually have a 1 week out motor vehicle accident patient that came in my clinic in the last couple days. I've been trying to, do all the safety screening, all the integrity, cranial nerves, working through screening all these things, trying to make sure like he is appropriate. He has a really complex history. But he had a really weird subjective complaint, and I wanted to ask you guys about it. He was it's a little comical, but he said that I was screening for cranial nerves, and he was saying that he just smells like fart all the time. And I was like, I don't know if that actually means anything or if that's just him. Like,
Remind me where you live.
Nebraska.
Okay, I got a lot of East Coast bias. That may be normal. What nerve would that be?
There's spots like that in Colorado too.
Okay, fair enough.
Yeah, I mean that'd be olfactory. So,
Yeah. So you're
but
looking there at,
um,
okay, have you ever seen any olfactory nerve injury with any type of, basically, it's have to be either olfactory or it have to be in some type of integration area of the brain. So
well,
where I
he
would be
does
looking at
have
my
history.
lit review.
He does have history of multiple concussions, and I don't know if you guys probably have heard of Madonna. It's a pretty big like rehab place. He was there for for a year doing like concussion rehab. And he's had multiple episodes of that, so I didn't know if it was maybe related to possible concussion. He was the driver of going about, I think he said 55, and a car crossed in front of him in a T-bone accident. That was a week ago yesterday. So, just trying to figure out, like, I think he's mostly got a little bit of concussion going on, but more cervicogenic in nature with everything. His mid cervical on the right side, like 5-6, are fairly stiff, and reproduce headache. And his baseline headaches is like an 8. I got it down to 6 when I was working with him. Just doing some gentle PAs and traction and a little bit of soft tissue for the muscle tightness and tenderness. Another weird thing is his bicep was twitching quite a bit, and I went in and just did some gentle mobilizations, and the twitching stopped. So
Likely he's had a lot go on. So, did you do a lit review, look at olfactory nerve with cranial nerve dysfunction?
Yeah.
I didn't have like a bar of soap or anything. I just first subjectively asked about it.
Yeah, I know. Did you do a lit review, a PubMed search on it?
Oh, I haven't read anything on it, no.
Okay.
Yeah,
Yeah,
because
it's usually kind of
you can get smells like sulfur type smells, which is kind of that, smells like a fart sort of sensation, from post-traumatic or post-concussive issues to the olfactory system.
Okay. I
So if
mean,
he's had, if he's had, go ahead.
a lot of his complaints are occipital area too. So just like tenderness, and then his headache will increase a little bit with pressure there.
yeah, I mean,
Yeah, go ahead, Dave. You can start.
if he had olfactory nerve injury, I'd expect he'd have a whole myriad of different things. It's not just going to get it in isolation.
Yeah, really unlikely. The olfactory nerve is
Okay.
a little weird because it's not actually in the brainstem. It's actually a part of the brain itself. So it's not generally in the same vicinity as some of the other cranial nerves. But like Dave was saying, having it in isolation without any other neurological components being either reported or elicited with testing would be weird.
The only other thing that is really weird, and I'm trying to figure this out. He reported like history of double vision, but the double vision is like not new. Like he's had it for like years. And he said it just always has like a little bit of like a blur to his vision. I asked him like, when's the last time you went to your eye doctor, and like, do you wear contacts and things like that? And he's like, well, it's been like 2 or 3 years, but he has prism glasses for his concussion history. He hasn't been using them at all, but he said it got a little bit, like he said it got slightly worse since the motor vehicle accident. Um, so I've had him try and do some gentle like convergence exercises and small range VOR exercises. But I'm just getting started with them. But it was really weird. I was like, I don't know if this is necessarily a red flag, but it's definitely like orange yellow. Like, I want to keep an eye on this. But
Yeah. Well, here's the other possibility is when we're dealing with the potential for, unusual symptoms, especially as they relate to the head, face, neck area. Um, because if you think of the cervical spine itself, right, and you have a segment we talked about last week, right, in our case that we did last week, cervical facilitations, right, and so facilitations in from the cervical spine, you expect to see those symptoms either in the shoulder girdle area or maybe down into the arm, right? That's the reference that occurs from those. You can have cranial nerve facilitations, okay, and that those you would expect to see within the distributions of the cranial nerves, right? So, but they have strange symptoms that pop up as a result of them, right? So, I don't think have we talked about this at all yet, Dave? Trigeminal facilitation? I don't think we've even mentioned
Sort
it.
of briefly, but I don't know they
Yeah,
went into great detail on it. I think we're saving
probably
that for
in
like
passing,
later
if
modules.
yeah, probably just in passing, if anything. But so the trigeminal nerve acts like a relay system. So when we have facilitation in the spinal segments, right? So in the cervical segments, the lumbar segments, things of that sort of nature, there's a portion of the neurological system called the substantia gelatinosa, and it's basically this interneuron pool, right? And this interneuron pool is where we kind of regulate whether or not some of these feedback loops are going to just come in and stop there, or they're going to continue through and create some sort of motor output going in the other direction, right? So the trigeminal system, essentially, the spinal trigeminal nuclei, essentially, is what it really ends up being, is a continuation of that substantia gelatinosa mechanism into the brainstem. Okay, so anytime there's substantial, feedback orientation issues, which is, to say these abnormal sensory feedback loops that occur high in the cervical spine, because supposedly from the anatomical um, research that I've done on it, it goes down to about C3, maybe even closer to C4. So if you have issues, hypermobilities, instabilities, even just painful segments, things of that sort of nature, higher in the cervical spine, it can create these trigeminal facilitations. And what this does is, because I say almost, it seems like there's connections from all the other cranial nerves to this trigeminal system. And it's like a relay center for us, right? So if the trigeminal system gets facilitated, we can have abnormal symptoms that we brush off. Things like, funny tastes in your mouth, tingling and such in the face, right? Um, ringing in your ears, ear pain, eye pain, sinus pressure, um, pain in the joints between your teeth. Things like it can cause trigeminal cardiac reflex issues, which can affect your heart rate. It can cause churning of your stomach. It can cause there's suggestions that it can cause nightmares and anxiety. That there's all kinds of different interactions. It can certainly cause things like dizziness, head pain, all these different things, jaw pain, all this different stuff, right? So sometimes we get these weird symptoms that'll pop up, and we don't know like, how are these things all interconnected? And it's just like, well, okay, so the idea of abnormal smells, things of that sort of nature, is it a cranial nerve deficit because there's something that damaged the olfactory nuclei during one of his concussive incidents? Or is it possible that it's just being ramped up because of some sort of ongoing cervical dysfunction that's affecting that trigeminal system, and that then is secondarily affecting the olfactory system? That, to me, would seem a little more likely to have something, kind of relatively, maybe it seems like it's in isolation, but it's not, because then you can couple it with things like the headaches, and any of the other symptoms that you're talking about, right? Because that starts to unify some of the symptomology that you have, rather than it just being this weird outlier where it's just like, well, maybe it's this olfactory system. There's two different mechanisms to this, right? Same as we look at with radiculopathy, everything gets turned down, right? So that's the thing that we tend to look at with cranial nerve testing, is we're looking for deficits, right? For reasons why these cranial nerves are not functioning correctly. But there's the reverse of that too, where it can be wound up, right? And so maybe it's more likely that situation, since you did find some stuff in the neck. Um, I don't know. Like I said, like I usually say, it's hard to tell you, give you a good quote unquote consult with this stuff without looking at the person in question, right? But it's a possibility that something like that is existing as well.
Just a little demographic on him. He's very, very bright 23-year-old. He's actually a medical insurance salesperson. He told me this morning when he came in that he went on a treadmill, incline level 15, 5 minutes, and he stopped because he had a headache, but he was able to functionally like do it. And so I'm thinking that some of the like more like um malicious things are not necessarily as strong. Like they're there, like they're in my thought process. But if he's feeling comfortable to go and work out, um then I need to be aware. But also I think he's not necessarily in immediate danger either.
I mean, you'd hope not. I mean, I don't think I remember hearing how long ago some of his issues were and, what the onset was with this issue that he's having currently. But
Mhm.
yeah, I mean, if it's been like an ongoing issue and, some of these things some of these, um, concussive incidents that he's had and motor vehicle accident stuff and all that is further down the line, then yeah, you can start getting less and less concerned about some of the stuff, some of the more sinister type things that could be underlying this, right? But you can't always rule everything out, right? Because that's just some things like we were saying earlier, they do slip under the radar a little bit.
Yeah, I mean, this would be somebody where, I mean, he easily kind of scoring pretty high on the Buffalo treadmill test is what you're kind of telling me from this, that, okay, he's getting a headache or getting any autonomic symptoms or recurrence at a high level of stress. It took a high level of stress to basically reproduce the symptoms. So what you ask him then is, okay, you're at this level, what's your heart rate and what's your output? And then you're going to try and bring him down underneath that level a bit as far as his training, just so he's not stimulating symptoms in that range. But still, if he's at 50% incline, even in walking, he's at a high level Bruce there. So he should be putting up pretty good heart rate numbers and blood pressure, with shock to the system. So, but he's gonna be a mixed bag of things with a multi-history of concussion. But that's actually, if he's going 15%, for a decent period of time, that's a pretty high level. All right. Let's come back in here and take a look at what we have. We talked about a bit of the dizziness in here, where again, no previous year history with dizziness, and the dizziness here, we're not really describing the type 1 dizziness that we'd expect to see. It's not, okay, I'm getting up out of bed. It's not really kind of giving me that BPPV thing where I change positions and I get, 30 seconds to a minute of severe dizziness with that. But again, those things are testable, and we can help kind of rule those things out further. That's more part of the bias correction, not my initial exam. Because if you do every single test to every single person, now all of a sudden you have a whole bunch of data sometimes and not a clear focus in what you're doing. So kind of screening through this dizziness is good, and kind of saying, here's what my underlying hypothesis is, and following that thread versus, okay, let me do every dizziness test under the sun. But again, on the back end, I do like to kind of come back in if I need to. This person had dizziness. How do I put in my note and tell that next person, the medical provider, that, okay, hey, we're rolling out, we really don't think it's BPPV because it's not positional. We did this did not reproduce the symptoms. Doing the ocular motor screen is helpful, and also showing, okay, is this centrally generated, or is this more peripheral in nature, or is it more, peripheral nature and cervical? Big factor to look for in this, and like the model differential, is if I can couple the neck pain and the headache, that's actually kind of a good thing. Because that way I can say, okay, it's more likely to be cervogenic dizziness. If I have headache and dizziness that is not coupled with neck pain, it appears to be separate, then I need to really look around and really decide, okay, is this truly cervogenic, dizziness, or do I have another cause of it? So the coupling is quite helpful to a degree to say, kind of, yeah, I'm further convinced that this is going to be from a cervogenic origin. Vestibular insufficiency at this point is unlikely, because again, we talked about testing the cranial nerves and scanning them real quick is helpful. We haven't necessarily done it in the position testing yet, but we can have that. But what Eric also talked about, like, and he and I will think about, okay, you're 2 weeks out. The fact that you didn't have some kind of an intimal tear, in my mind, okay, it's still in the back of my mind there. So I'm not thinking, hey, I'm gonna go in there and whack this thing right away, go for the home run shot. I'm thinking, I'm gonna hedge my bet a little bit with this, because though you're not showing, okay, signs of VBI, I don't want to be the cause of the VBI either. So I keep that in the back of my mind as I look at this individual. And again, here we're seeing type 2 dizziness, Yeah, that's what we're talking about. And the cranial nerves, as he looks at here, is I'm just reading the last sentence here just to make sure to put it there. All right, Joey, what do you think about this last part? Because cervical rotation combined with extension reproduces her dizziness. These movements are also stressful movements for a single vertebral artery. This diagnosis cannot be excluded in the history alone. And the most likely cause of this will be a cervigenic joint, but remains a concern of contraindication with the vertebral main concern of vertebral artery condition. Again, we talked about a little bit. What would be your vertebral artery screening process to say, hey, listen, I think this is cervigenic dizziness. I want to be kind of further sore. What do you do next?
Are you asking what would I do to rule out a vertebral
Yeah, what
artery
comes next?
issue?
He's giving us to say, okay, we're concerned here. Think, okay, what's the worst case scenario? What's the worst thing that could be? Pretty sure this is going to be, again, cervical spine. How would I rule out vertebral artery? Or strengthen my thought process that this isn't vertebral artery? First
So
off, which vertebral artery would it be if it's with right rotation?
if it's with right rotation, wouldn't that be the left one?
Yeah, good.
So my typical, I'd want to do cranial nerve assessment.
hmm
I would want to do the vertebral artery insufficiency testing is what I would do. But the only concern would be if you said right rotation and extension are painful, right? So when I test that, the symptoms I would be looking for, even if they're going into that position, would be that I would do another cranial nerve testing while they're in that vertebral artery insufficiency position to then see if that's symptom provoking rather than just the pain response, but have it be like, are you able to track my finger? Are you able to smile and test cranial nerves in that position as well?
Yeah. And in the first module too, I know that's a while ago, we talked about like the, progressive, modified to like declines testing, which is gonna be positional testing. You test neutral in first, and this is right rotation extension. What I would do is I would test it in components. You may test, okay, left rotation extension, pure extension, and then go into that last test later, just to kind of screening as a process. It's also kind of strongly recommended too. If you're looking, if you're cautious with somebody pre-manipulative holding, that would be kind of probably the best standard to do is to do the graded vertebral artery testing.
Okay.
Yeah, many times what we do is we take them right to that position. Okay, here's the position of provocation. Okay, let me extend, rotate you, and test cranial nerves in that position. Jimmy's doing a video, and somewhere in the files here I can dig it out where Jim shows a positive declines test where they do this in the individual and they have a positive vertebral artery. The video looks like it's from the 70s, back when you do that stuff to people.
I think I've seen that one. That's the one with the nystagmus.
Yeah.
Yeah.
And he's asking him to count back from 10 and it falls apart.
It's creepy. It's a little
It
eerie.
is a little creepy. I got a little creepy too. It's kind of a funny looking video, but yeah. So going to your examinations, we talked about cranial nerve long tract nerve tests. We think, okay, we want to rule something out. Let's look to see, do we have anything of higher origin? We can be in there. Like I would probably do vertebral ligaments maybe further down my list of where I'm going to do it. I may be looking at body rotation tests and dizziness reproduction tests first, and then dropping into vertebral ligament stress testing down the line. Austin has his hand up, it looks like.
I'm just full of questions
Austin.
today. On the vertebral artery screening, I was initially taught to do it in sitting, with the rotated and head extended, and then I was taught during my vestibular training course to not do that, or just don't test it in general because you're kind of inviting potential stroke. But then we talked about it again in module 2. What I'm gathering is we need to test it, but we probably want to test it in a supine position with the head rotated and extended. Is that correct?
It's usually
Or
how
does
I would
sitting
do it.
versus okay.
Many times what you do is you do what's that Hotens test too, or okay, if you're doing it seated, you can put the arms out straight and look to see if you can do the arms deviate. you know, that can look at also kind of just if you're doing it standing, and that's more of a balance test. But I've seen that one done as well. Vestibular people are scared to death of the cervical spine. It's one thing you got to take into account if you're getting it from a vestibular course. They're afraid that they're going to stroke everyone out. They do a, you know, a Dix Hall pike on. And it's just the nature of vestibular people. They're usually generally as a group very, very afraid of the cervical spine. And they think that, okay, I put somebody in this position, I'm going to stroke them out. But it's probably, you know, pretty far from the truth. But I know, you know, a lot of people teach in big vestibular programs, and they're all like, ooh, cervical spine, you know, I don't know. So it's probably where that comes from, the culture of that. I mean, I'm making an assumption there, but it's kind of educated. It's kind of an educated statement.
The one thing you have to take in consideration with doing testing in seated is if the patient were to, you know, not necessarily lose consciousness, but if they were to falter, how are you going to be able to protect them? Right? Because the last thing you need is somebody falling off your table. Right. So the idea of even doing it in supine, because a lot of the ways that these tests are taught is to drop the head off the end of the table. And if they lose it, right, if they go whoop, and they're out, what are you going to do with their head hanging off the end of the table? Are you going to push them back onto the table using their head? So you got to make sure that the suggestion of doing it in supine and with the head supported, and you can drop down the head of the table if you need to a little bit, but it's easier just to lift the neck to create extension rather than dropping it off the back of into the table. Is more about, you know, what's the worst that could happen here, right? So the idea if you're having them, if you're doing, you know, true not craniovertebral, true vertebral artery testing in seated, and the patient loses consciousness, they're going down, and there's going to not be a whole hell of a lot that you're going to be able to do to help them. And at that point, they're in a position of impingement or some sort of position of insufficiency, right? So going down and their neck whipping around without any protective mechanisms is a bad deal, right? So that's kind of the typical reason why I would want to do a lot of this testing in a supine position. But some of these things, body rotation test, you have to do in seated, right? So that's just kind of the nature of the game there. But again, you should be, because this is a graduated process going from least stressful down toward more stressful tests. You should have a pretty good idea going into some of these things that you're looking at something that's not normal, right? At least that's the hope. And we're basically, if you think about it, what we're doing is we're putting progressive stress on the artery with hopes that that monitoring the central nervous system as we go, which is why we're looking at cranial nerve testing in the first place, right? We're using that central nervous system as a monitor for the vascular system, right? The vascularity of the central nervous system. And if we start to see a decline in function as we increase stress on the artery, that, you know, the function of the central nervous system, then we're pulling them out. We're not going any further. When we start to see that decline, we start to see something come back as positive. We start to see something that might resemble a red flag for us. We're saying, that's it. We're done here. Right? That we don't need to go any more stressful from there. Right? So at that point, it's just a simple thing. It's just like, well, we got to stabilize the neck, make sure they're safe here. They need some angiography done in order to test out the artery itself, or Doppler sonography, something of that nature, to test out what that artery is doing. So again, this is the whole purpose of the graduated process.
You kind of butt up on it here. You can see that as you get in here, the cranial nerve examination was negative, you know, except that during ocular tracking, the patient experienced mild vertigo when looking to the right and upward. Why would that be the case with a negative cranial nerve examination? We're still beating up on Joey. Maybe we'll beat up on Joey one. Why do you think that would be the case? Don't give you that again. This person has no cranial nerve involvement. Joey may have ducked out. Nope.
No, I'm here. I'm here. I don't know.
Sir. I like when you think about the direction we're going into. Looking up in that quadrant is the quadrant of pain.
Okay.
Would be my guess. So you're going in there. What's going to happen is you're probably going to have a mild Jim's probably alluding to is a mild integration problem because you're not going to move at the speed. The eyes, the suboccipital muscles, upper cranial vertebral region, highly innervated, matching the eyes to coordinate motions. Well, if I have pain there and I'm inhibiting it, you usually get a dyssynergy. And I've seen this one before in people, with upper cervical dysfunction or mild post-concussive things with neck pain, and that they'll get that mild dizziness, which goes away. It doesn't last for as long, but because they're not matching speeds because of some of the inhibition, because of the pain or restriction, they can kind of get this mild vertiginous moment because they're not integrating properly. Think about the image on the eye doesn't match the speed. So
Yeah.
you'll see that occur. It's going to
And
match what comes out.
You'll see these things all the time too, because the kind of modified version of the declines is something that you'll do even if you have somebody that's non-traumatic and you're kind of getting them, okay, this is the position that I'm going to do my technique in. I need to see that their vascularity is going to function in that position. So you put them here and you'll do a couple of cranial nerve tests. So the eye tracking is a really easy one to do. Just follow my finger. And what you'll see is particularly when you're going toward the direction of dysfunction. So in this case, that right looking up in that direction, especially if you have them in a provocative position to begin with, is you'll see the eyes they'll flicker, right? It's not this nice smooth pursuit as they follow your finger. It'll be here and then it'll go doink and it'll jump almost. And so the eyes they're not matching up with the images correctly, right? And so that's a very easy thing to kind of all of a sudden set off this kind of, whoa, where am I in space here? Because they need to reset. Right, so you'll get this maybe little twirling version of a nystagmus for a moment. And I don't even know if you technically call it a nystagmus, because it's kind of in and out with the movement. But you'll see it a lot, and it's actually not a bad thing to be able to do to test to see, okay, yeah, it tells me there's something wrong on that side as they're in that position. So you'll see that quite a bit.
It's a good long discussion to get into what somebody amounts to having a biomechanical dysfunction at C2, C3 on the right-hand side. But the thought process is good because this is kind of, you see how this thought process as we do it is robust. We end up with a biomechanical dysfunction, but anywhere along this pathway, we bump into something else, then, our differential deviates, whether it's, hey, I get a positive alar ligament, stress test, or I reproduce these symptoms with a VBI test. Or okay, and I do a head rotation test, and I stimulate what's more indicative of vestibular dizziness. Everything that we chat about today is kind of like we cover a great deal of the differentials, which is kind of the important part of that. That's kind of what we do on our way to saying, okay, yeah, this is a biomechanical dysfunction, but I just don't look at this person like, boom, this is C2, C3 biomechanical dysfunction. Let me go and manipulate it. My thought process leading up to, in this case, I probably wouldn't manipulate them if they're 2 weeks out. I would probably choose some other graded manual technique or kind of keep everything pretty still. Or how do I get this to release? That's not going to be a grade 5 manipulation. But this is the process that goes through in my mind and in my reasoning process to get there. And it's kind of where we like you, that's where our goal is to be with this, is that sometimes these things happen very consciously and organized. Other times in the back of my mind, I'm filtering out this information and asking the appropriate question. And once I'm pretty sure this is a biomechanical dysfunction, I'm going to go ahead and do my bias correction just to make sure I'm not missing one of the obvious, more sinister things as well, just to be sure as I kind of go forward. This person's 8 weeks out of this, then I may be slightly more aggressive with that C2, C3 joint in my manipulation technique. Where I think Jim he'd be more comfortable manipulating this at that interval. I think Eric and I tend to be a little bit more cautious based on just the vertebral artery data.
Yep.
I'll set these cases. There's other cases in here. We may do another one next week. These cases we usually have done in, usually done in module 6, but sometimes you run out of time to do these cases in module 6. So it's good to go through this clinical reasoning process. We'll definitely try and do at least 1 or 2 of them there. But it's good to kind of take a longer period of time and kind of tease through this process as this starts to become your process. How you use all the information we've gone over. Good. Hey, good job, guys. Paul, Joey, Mitch, even Alston. All right. We'll call it a day. All right, guys. My next